So my name's Janet. I'm a Continence Nurse specialist based at Green Lane Clinical Centre, just down the road there. I'm a community nurse. I visit people at home with bladder and bowel problems, which is always a good conversation stopper when anybody asks me what to do for a living. They always say, oh dear. If they're under 30, they say, well, what problems do you have with your bowel and your bladder? And if they're over 50, I get the whole lot. So there's a little cartoon I always like to start off with because it's quite amusing. So that's who I am. So I'm based at the hospital down the road. I currently have 2,000 patients on my books and I'm the only permanent nurse there. We get about 30 new referrals a week, and that is actually increasing as the population's getting older and sicker. We're getting more and more patients through with bowel and bladder problems. So unfortunately, I have quite a long wait list of 10 to 12 weeks. It did get up to 6 months until they finally gave me some help. So it's not good at all with what is happening in the continence field. As has been mentioned before, the government aren't interested in funding continence. It's not sexy, it's not exciting. It mainly affects older people, especially older women. And it's a thing that people often think it's because I've had babies, I've had children, it's my age. And sadly, as the previous speaker said, a lot of GPs tell patients it's because you've had 3 or 4 children, it's because you're getting old. And that's really sad because there's always something we can do. Even if it's only to provide you with a pad, there's often other things we can do to help as well. So that's what I do for my job. I promote continence. I'm not the incontinent nurse, which most of my referrals, a good 50% of them come to the incontinent nurse or the intercontinental nurse. And I did have the incompetent nurse, which was, I hope that was a typo. That was a bit insulting from a GP. But mainly my referrals come from family doctors, because that's usually the first port of call for people to go to. And also hospitals, rest homes, caregivers, or anybody can refer really. I get very distressed people ringing up, absolutely desperate, can you help? So it doesn't matter if you've not gone via the GP, but it is helpful to us if you have, because then we get a list of your current medications, and people often forget they've had a hysterectomy or they've had a prostatectomy 30 years ago, and that's important that I know about these things. So ideally a referral from your GP. You don't have to go and see them, you can just phone up the practice nurse and ask her to pop a referral through, and she'll make sure I get all the right information. It's always very sad when people have had a problem for 30 to 40 years and been too embarrassed to tell anybody. We're trying to promote continence as something to talk about. You know, there's no shame, we're all the same, as the Embarrassing Bodies series has promoted a lot about continence, and I have had a lot of people coming forward after they've seen that programme. Because a quarter of the population are incontinent. So next time you're walking around the mall, there'll be a quarter of the people in there will actually be incontinent. It's a huge problem. 1 in 3 for ladies who've had children will leak at some time in their lives. So you're not alone. Say I've got 2,000 people and I just cover central Auckland. There are continence nurses all around the country. So if you live elsewhere, we've got them dotted all around the North Island and the South Island. So there's always somewhere you can get help. Now some of the things will actually overlap with the previous speaker, so I won't go through a lot of these, but I'm just going to talk about the main types that I usually see. There are lots of different unusual types, but the most common one is the stress incontinence, the urge, and the functional. The functional is the main thing that I focus on, because a lot of patients with PD or any other kind of neurological disorder, or just elderly people, they just can't get to the toilet in time. You get the urge, and by the time you've stood up, got yourself organised, got the walker, halfway there, you've wet yourself. So it's not actually often an incontinence problem with the bladder, it's a functional problem, just getting to the toilet. And I'll also talk about fecal incontinence. This affects more men than women. It's a lesser percentage than bladder, but it's a hugely distressing condition, one that people are really ashamed of, and it's often the one that gets hidden. It's an awful thing to be fecal incontinent. You can imagine if you go out to the supermarket and you do an enormous poo and it's dreadful. It's the worst thing that can happen to somebody when they're out. So we do see quite a lot of that, sadly, people who've put up with it for years without realising something can be done. People are terrified to go to the doctor because they think the doctor's going to be embarrassed. But, you know, we deal with orifices all day long, day in, day out. So it doesn't matter which part of the body you're talking to, it's just another part of the body to us. So it's really important you go there and talk to somebody. Don't just hold on thinking it's too embarrassing for everybody, because it's not. And so the problems we get with fecal is diarrhea or loose bowels, or dysentery, as some people call it down here. Incomplete emptying, where you can't empty your bowel properly, so you'll have an incontinent episode later on in the day. Functional again, you get the urge to go and you just can't get there in time. And impaction with liquid overflow, that's something we see quite often. The constipation gets so bad, the bowel becomes hugely compacted with solid, hard rocks of motion. The longer it's in the bowel, the more water gets absorbed out of it. That's what constipation is. It's sat there in your bowel, your body absorbs the water out, and it gets harder and harder till it's like sets like concrete. It's solid, rock-hard lumps. But when you get liquid overflow, that's where the bacteria work on that big solid lump, and it dribbles down the side, and you've no control over it. And often patients end up having to go in hospital to be disimpacted, either manually, or some patients have to go to theatre to be cleared out. They've got weeks and weeks worth of solid poo in the bowel. So you can imagine how distressing that is. It's pretty awful. So we do see quite a bit of that. So stress incontinence, that's already been mentioned, but childbirth is the main cause. Obesity, if you've got a lot of obesity, especially around the truncal area, you can imagine the weight. I got lots of patients over 100 kgs in weight. So your poor little bladder with a massive amount of a huge tummy pressing on it will just squeeze the urine out. The poor bladder just can't hold on against all those forces of nature. And straining to have your bowel open is a big no-no. So many patients sit on the toilet in the morning and force themselves to have a bowel motion. This is the worst thing you can do. You'll damage those pelvic floor muscles and end up with urinary incontinence as well as fecal incontinence. And heavy lifting, with men, if you've had a heavy lifting job, that can cause stress incontinence. And post-surgery, if you've had any surgery around the bladder area, that can cause it as well. So treatment for stress, that's already been mentioned. Pelvic floor exercises, may need surgery. Losing weight makes a huge difference to the bladder, and stop straining. That's really, really important that you don't do that. Overactive bladder, that again has been mentioned. Urinary tract infection is the first thing we think of. When I go to see a patient, I eliminate all the main causes and work through a little list of things it could be. Constipation can cause an overactive bladder. The solid motion in the lower rectum triggers off bladder spasms. So it's really important we get the bowel working properly for the bladder to work properly as well. Post-menopause, Ovestin cream's been mentioned. And having surgery or a catheter inserted. I get lots of patients who've had a catheter put in after surgery in the hospital. They take the catheter out, send them home, and they've ended up with an overactive bladder, which we then have to treat with medication. So as a continence nurse, to me, an indwelling catheter is an absolute no-no. We don't fit those unless it's an absolute last resort because of the problems patients can end up with. An enlarged prostate, that can cause incomplete emptying, that's been mentioned. And fluid retention in the day, whatever you pool in your legs in the day, gets absorbed overnight when you're laid in bed and comes out as urine at night. We get lots of patients who only go once or twice in the day, and then they're up 7, 8, 9, 10 times at night. Some patients are going every half an hour every night, and they're passing up to 3 litres of urine. And they're wondering where on earth it's all coming from. That it's whatever pulls in the legs comes out at night. And also as we get older, the kidney doesn't produce as much antidiuretic hormones. So that's why when you're in your 50s, 60s, you'll get up once at night. In your 70s, you'll be up twice. And then in your 80s, you might be up 3, 4 times. Because you're producing more urine at night than in the day. And we can manage that with, if the patients are suitable, to have some furosemide, a diuretic, at tea time. And that gets rid of all this excess fluid before going to bed at night. So that works really well. And excessive fluid intake. This is something that doctors don't check with patients unless you're actually a urologist. But how much fluid is enough fluid? I get this question all the time. There's a bit of a misnomer out there that we need 8 glasses of water a day. That's not correct. You should only drink when you actually feel thirsty. Your body regulates the fluid itself. The problem is, as we get older, the thirst reflex goes, as well as your eyesight and your hearing. Your thirst reflex drops as well, so you don't feel thirsty. The least I ever had was a little old lady who was having 1 cup of tea a day and nothing else. She just didn't feel thirsty, couldn't see the point. So she was having terrible urine infections, the blood pressure was in a boot, she was falling all over the place and she'd broken her femur because her blood pressure would be so low because she's not drinking. Then you can have too much. One lady was having 8 litres of water a day because she thought she got the 8 in her head and was forcing herself to drink 8 litres of water on top of teas and coffees and juice. So I just walked in the house. She was going to the toilet every 30 minutes, day and night. And I just walked in there, and there were bottles and bottles all over the sitting room. So I immediately sussed out what was happening. She was drinking gallons. She'd been in hospital with hyponatremia. That's where you've washed all the salts out of your blood. And nobody had asked her how much she drank. They just said, do you drink plenty? Oh, yes, that's what everybody says. If you ask them if they drink enough, they'll say yes. But how much is enough? People think 1's enough, up to 8 litres is enough. My record for coffee was 42 mugs of coffee. I had a patient referred with diarrhoea of unknown cause. He'd had lots of investigations done, couldn't see why he'd got the bowel problem and going to the toilet every 20 minutes. It was a back injury on ACC. And I walked in the house and immediately, again, before I'd even said a word, could see what the problem was. He lived in his lazy boy. He was a gamer. He'd got the big bank of games and all the stuff there. A kettle and several big jars of coffee and huge big man mugs. So I immediately sussed out he was a gamer. He'd be up all night playing games with people all around the world, drinking coffee to keep himself awake, because my son does that, so I recognised the signs. And so all I said to him was, how much coffee are you drinking? And we worked out he was having 42 mugs a day, because nobody had ever asked him in the hospital how much he actually drank. And coffee's a laxative, so that's why he got the diarrhoea. It causes the bladder to contract, so he'd got an overactive bladder. So all we had to do was wean him off the coffee, which was a hard job because he was completely addicted, so he had major withdrawals until we got him off it. So that's all we needed to do. He was back to normal after a couple of weeks. So you only need to have 7 or 8 drinks a day. A drink is sort of a small mug or a small glass. Ideally, it should be 2/3 water because our bodies are sort of 80% water, so we need water. Avoid anything with caffeine. Caffeine causes the bladder muscle to contract. So that's tea, coffee, Milo, anything with chocolate in, and these V drinks. A lot of people are having these V drinks. They're full of caffeine and guarana, which gives you an overactive bladder. Milo is traditionally a thing Kiwis have before bed. Worst thing to go to bed on because it's got caffeine in. So we teach people to not drink a couple of hours before you go to bed and have your Milo. You know, either don't have it or have it earlier. Alcohol is a diuretic, so you don't want to be having alcohol in an evening either. Whenever I ask people how much they drink, you always know they're underestimating. They're not going to tell you exactly how much. I've had patients who only have a little glass of whiskey, and his wife, I can tell by his wife's face how much he's having. So you need to ask how many pub shots you're actually having. And one gentleman was having 8 glasses of whiskey before he went to bed and was wondering why he was up all night peeing because it's a diuretic. So he just said, that's fine, but start earlier in the day. If you're going to have your gin and tonic, start at 4 o'clock instead of 8 o'clock. So we don't want you to stop having the alcohol if you enjoy it. So it's really important that you look at how much you're drinking. So 7 to 8 is plenty. But some people 6 or 7 is plenty, but you don't need 8 glasses of water a day. It's too much. It washes the salt and potassium out of your system, and you can end up with an irregular heartbeat and end up in hospital, which I get lots of people who've ended up in hospital because they drink too much. So that's really important to check that. So what we do first is we check for urine infection, check the caffeine intake, treat constipation, and looking at functional issues, so a urinal or a commode, actually getting to the toilet. Some patients can get there, they can't get off the toilet, which can be a big problem. So I've got access to all the equipment I can order for round the toilets, which have got round toilet seat with handrails on it. We can get handrails fitted. There's lots of other equipment we can help you with to get you to the toilet. If getting out of bed's a problem, we've got bed levers. You might have seen those. It fits under the mattress and you can pull yourself up. We can get you a commode for by the bed. Urinals work brilliantly. You don't need to spend $40 on a flash one. You can just use an empty milk carton. That's fine. Some people prefer a bucket because it's a bigger area for them to aim, or some wives prefer a bucket because gentlemen aren't very good at hitting things, as we all know. And bladder retraining programs, that's what I do. That's my job, is to try and get this bladder back to functioning with using different things like deferment techniques, putting off going to the toilet, because there's been mentioned, if you're busy and you're doing something, you're watching the telly, reading the paper, you're fine. But the minute you think about it, you need to rush to the toilet. That's called deferment. So I teach bladder retraining programs and get people back onto a normal voiding pattern. The normal amount of times you should void or go to the toilet is 8 in 24 hours. So 1 before you go to bed at night, 1 when you get up in the morning, and 6 in between. That's an average, but some people obviously more, some people are left. But that's sort of your average, is 8 in 24 hours. Medications, that's been mentioned, and continence products. So that's what I do as well. So I've got some things here to show you. Just because you are incontinent doesn't mean you will need to wear a pad, because hopefully I can fix your problem and prevent you needing one. But if you do need a pad, we've got to arrange that available on the health service. The problem is the health service will only fund 2 pads a day, which is absolutely appalling. They say, well, we've got pads, which hold up to 2.5 litres of urine. So you can have 2 of these a day. Now, who would want to walk around with one of these on full of urine? A millilitre of urine weighs a milligram. So if you've passed 2 litres of urine, you've got a bag of sugar between your legs, and it feels like a bag of sugar. So who'd want to do that? We'd all want to wear 10 small ones and change them, but the government will not shift on this. 2 pads a day, and then you have to buy them yourself. We've been lobbying the government for years to try and get something done about this, but they won't. They just see it as money down the drain. They're not interested. So sadly, that's all we can offer you. Unless you are very disabled, needing full nursing care in a wheelchair, and I do see children as well, you can have up to 4 a day. But for the average mobile patient, it's only 2. So I get a lot of flack, a lot of aggro, a lot of upset crying people, because if you're on a sickness benefit and all you've got is a limited funding and you're having to pay for pads, it's disgusting, it's appalling. And there's nothing we can do about it. Over the North Shore, you get 1 pad a day because the accountants decided to halve the continence budget and patients over there get 1. I spend about $110,000 a month on pads, and I've been told my budget's got to come down. But it's appalling. I had a poor lady who was spending $250 a week on pull-ups. The local chemist was charging her $50 a packet, which is absolutely outrageous, and she was doing without food to buy a continence pad. I mean, in this day and age, that is absolutely appalling. The patient was incontinent because of a surgical procedure. She should be given what she needs to manage that. But because it's mainly elderly women without a voice, the government aren't interested. So we've got the contract for the Molicare products, which are a very good range. This is the smallest that the government will fund. This holds 600 mils. If you need anything smaller than this, I'm afraid you have to buy them yourself. The contract states you have to leak at least 400 mils or 2 large mugfuls of urine a day to get free pads on the health service. So this is the smallest one. There's a huge range available at the supermarket, at Nappies for Less. You might have seen those dotted around. And you can get them online as well, and the Disability Resource Centre sell them. But that's the smallest, and that's the largest. And there's all different sizes in between. This kind is a slip-in pad, so you fold it in half and pop it between your legs. You do it like that, and you hold it on with the stretchinette pants that we supply as well. They're disposable. They just go in the rubbish bin, like babies' nappies do. So there's a whole range of different sizes for different absorbencies, so we'll help you find the right one. Pull-ups. These are the big problem. Everybody wants pull-ups. These are $2.20 each as opposed to 43 cents for a slip-in pad, which holds the same amount of urine. But these are much more aesthetically pleasing, they're more comfortable, but they've just totally blown everybody's budgets, and this is why we have to only give these to people who can't manage the slip-in pad. So if you've got a neurological condition, then that's fine. So usually with Parkinson's, multiple sclerosis, something like that, we'll give you these. But these are really comfortable. They're an all-in-one. They're easy to use, and they prevent people falling, and they're much nicer. But these are available to buy in the supermarkets as well now, but we've got those as well. We've also got the traditional nappy style, but we only use these for people who are bedridden or in wheelchairs, because it's not very nice to be an adult and put in a nappy. And we've also got some other little bits and bobs here I've brought to show you. This is what we used to use years ago. This delightful little red rubber jobby. This is what people used to have to wear. It's actually called Happy Bobs. It'd be good for sliding down or doing a bit of sledging or something, but this is what people actually used to have to wear. And then it migrated onto these ones. These were the old washables that came in the 60s and 70s. Hideous. And I have nursing homes who are still using these, but they've been told off and made to stop them. One down in Epsom was putting patients in these. I mean, how appalling is that, to be wearing something like that and sit in it and being soggy wet all day long? So he got well told off for that and made him throw them all away. Then they invented these little things. These are red rubber continence products for men. Very glamorous. They actually still produce these in England. Actually, men in England actually like these, and they're really, really popular. They look hideous, but they do actually work. It's just a method of getting the urine into the bag. But this is one of the original ones I kept for doing my talks. And us poor ladies, this is what they came up with for us. I don't know why there's such a long tube. You can wee at a distance, but it's anatomically for ladies. So you were supposed to sit between that and wee into it. Can you imagine? It's awful. There's been all sorts of things through the ages. But we also do have Uritips. Some of you might have heard of these. I can never get a man to model one, so I have to bring my own model with me. But you might have heard of these. It's a condom drainage system. It might be called Uritips, or they've all got lots of different names for them, but here they're called Uritips. And it's a sticky, like a condom, it rolls on the penis and it sticks on there with adhesive. So you just roll it on. We have to measure you and fit you up correctly for these so you get the right size, because if it's too big, it'll drop off. If it's too tight, it'll cut the blood supply off. And I have had patients who've had to have the penis amputated because they've ended up with a necrotic penis. It was the patient's own fault. So we have to make sure you're fitted correctly. So I can size up a man's penis to within 2 millimetres. And they're always disappointed. Culturally, it's quite interesting. Kiwi men are only 29 to 32 millimetres, whereas in England they used to fit 36 to 40 millimetres. So, yes. So culturally, there's quite different sizes around the world with different nationalities, which is quite funny. So once I've assessed you for one of these and taught you how to look after it properly, they're really easy to use. So it rolls on, you attach your bag, and this is the leg bag for the day. That goes below the knee, and then you can attach a big night bag for night time. Some people just like to wear them when they go out instead of a pad, because you've got up to 500 ml capacity of urine, and some people just like to wear them at night for bedtime, because you can wee into it at night, you don't have to get up. The problem with them is most men are quite happy to have them put on, but it's getting them off, that's the trouble. You have to wet it and use hot soapy water, ideally get it off in the shower, roll it down, don't try and pull it off, as some people do. That's a bit painful. But they do work well, but you have to change it every day. Patients have a habit of putting them on and they don't want to take it off. So they leave it on for several days and then they get thrush and sore and nasty sores and all kinds of problems go wrong. So we have to be careful. They're thoroughly trained. And we usually train the wife, though, because she will normally make sure the patients do it properly. But we teach caregivers to use these. We supply them for children. I fit ones to small children, disabled children. And say they go up to a 40, but I've not fitted one of those here in Kiwi land. So usually it's a 29 and a 32. But they work very well. And we have good results. The problem is you have to have a decent length of a penis to put it on. So when you sit down, if the penis retracts in and you're left with a little button mushroom, it won't work. You've got to actually have a good, decent length to fit it on for basic plumbing. Now, previous speaker mentioned intermittent self-catheterisation. That's something that I teach as well. It's really good. So these are the catheters that you actually use. The little one is for ladies and the longer one for men, obviously. So we teach patients how to do this, how to pop this into the bladder and empty the urine, and then you take this out. And you wash it and reuse it for up to a week each. It's really handy because you can pop it in a little snap lock bag and put it in your pocket and take it out and use the toilet. The youngest I've taught is a 7-year-old girl, and the eldest is an 84-year-old lady, and everything in between. It's a really simple, been around for thousands of years. The Chinese started doing it with reeds. They used to sharpen a reed out of the river, and you might, it makes your eyes water. And then the Romans made them out of silver and used silver ones, but now we've got the plastic. But they are making the silver ones. Silver's back in vogue now as an antiviral, antibacterial, so there is a man who actually makes them in silver. But usually we use the disposable throwaway ones. So we do a lot of training of that because it's a really good way to manage incontinence. What time have we got to? Oh, better finish. Sorry, once I get started. Oh, we talked about that, uretips, self-catheterisation, and an indwelling catheter is an absolute last resort if there's nothing else we can do. Bowel management, constipation, we treat that with laxatives, but we try the natural methods first. We've got a really good bowel recipe with apples, prunes and bran. And Flow, that's got the kiwi extract in, and kiwi crush, which is sieved kiwi pulp you can get at the supermarkets. We try those methods first and looking at diet and fluids before we go on to laxatives. We try and get patients off laxatives and onto a natural way so your bowel can actually function as it's supposed to do with fibre. Loose bowels and diarrhea we treat with Metamucil. It's promoted for constipation, but if you don't drink enough, you'll get constipated with it. So we recommend that for thickening up loose bowel motions. Although Consul D's sort of taken over as the one of choice, it's a bit more palatable. There are medications to stop diarrhea. There's Imodium capsules, and looking at diet and fluids. And also we teach toileting programs. If you need to have your bowels open between 9 and 10 when the caregiver's there, we can put a program in place to do that, and providing a suitable pad as well. So just as a take-home message, incontinence is not a normal part of ageing. It's a symptom that there's something wrong. So if your GP tells you it's part of ageing, don't believe him, ask him for a referral. You can ring us on the numbers there, and I've got some information at the back if you want it. And also the New Zealand Continence Association have got an excellent website if you want to find out where people are around the country. They've got lots of really good resources on there so you can read up about continence. Okay, so that's me finished. So any questions?
My husband thought it would be a wonderful thing to have one of these bidet things that's electric.
Oh, the bidets.
Oh, yes,
they're great.
That it's got a function on it called enema wash.
Oh, animal wash.
Enema wash. It's
Enema?
Enema wash.
What goes up your bottom?
Yeah,
That's
it's kind of
incredibly
a firm
dangerous.
Spray. I wondered if
no,
you had
no,
any
no, no.
commentary about that.
Absolutely not. You know, enemas have to be given by a nurse in a controlled environment. You can't squirt water up somebody's bottom. You're going to end up perforating the bowel. That's highly dangerous. You need to be examined before anything goes up in your bottom. Because you could have a prolapse there, you could have hemorrhoids, a fissure, all kinds of things. So it's because when I'm assessing somebody's bowel problems, I always do a rectal examination just to check if there's any abnormalities. But that's definitely highly dangerous. Yeah, you mustn't do that. That's horrifying.
Ye God, what is ahead for all of us? Thank you for today. I've heard of an Australian company now that manufactures a computerised device that goes in a pad, mainly designed for people who are not very highly functioning in their...
Oh, like a wetness alarm.
Yes, it's an
yeah,
alarm
we've got
that goes
those for
like...
children. Yeah, we don't
these?
tend to use them for adults, but they are they're not funded, so you'd have to buy your own, and they're about $400. Children can borrow them from a clinic, but they're not available. You've got to buy those online, but they do work very well. Yep, they're a good idea if you can buy them. Yeah.
In terms of a simple way of approaching that, what I often do is use an old-fashioned watch and get an alarm on the watch for patients who forget to change, and every time the alarm goes off,
Oh, yes.
you have to change.
Yeah, if you do,
Much cheaper.
We do timed voiding. That's one of the things we teach you, to go to the toilet every couple of hours. So people can do it on the phone nowadays, the app, or on your phone, on your wristwatch as well. Yeah, that's one of the things that we teach. Yeah.
No more questions? No, oh, yes, another.
On your constipation list of things to do for it, the first thing listed was a bowel recipe.
Yep.
And I wondered what that was.
It's apples, prunes and bran. So it's 2 cups of stewed apple, a cup of... I can write that down. Do you want me to write it down? Have you got photocopying here? Yeah, you can email it out. Yeah. Yep, I'll email you because it's a really good thing. It makes a huge quantity, but you can freeze half of it. It looks revolting. It's a purple-brown slush, but it tastes really nice.
Or share it with your friends.
Yeah. Some people call it bowel delight rather than bowel recipe because that sounds a bit...
Could you just speak about it anyway? Because for those of us who are writing, we could just jot it down.
Oh,
quickly.
yep. 2 cups of stewed apple, any old apple or tinned if you can't be bothered stewing it. A cup of prunes that you've soaked in boiling water. And 2 cups of baking bran. That's the bran you'd make muffins with. It's loose in the bins in the supermarket. And then you blend it all together in your blender with the prune juice and have 2 big tablespoons for breakfast. So it's highly nutritious, it works really well, but it's got a lot of potassium in it, so if you've got a kidney problem and you can't have potassium, you can't have it because of the prunes. But it gets the bowel working in a normal, natural way, and it tastes really nice. And you can have as much as it if you want. Some people need a bit more. But and if you have a kiwi fruit with it, usually things work really well. Yeah. So we try and use the natural way before going on to laxatives. Yeah. Anything else? All done? No, thank you for listening, and I hope if anybody wants to come and see me, I'll hang around at the back because often people want to come up and have a quiet word after, so please feel free if you want to ask me anything while I'm here. Or you can just phone if you want to.
Oh, thank you for sharing this with me, Janet.